Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 138. With some good luck, most of us will get vaccinated soon, and that may be the beginning of the end of the COVID crisis. Stay safe during this, and welcome again to today's webcast. A very unique case today with I went through the database and we've had about almost a dozen similar cases. Today's, I think, is going to be even more challenging. It's highly angulated lesions. In my mind, the two areas of coronary PCI that have had the biggest development in techniques and new devices has been in CTOs and for the crossing of angulated lesions, and hopefully you'll get to see some of those and have a very useful discussion. Today's session is also special for us at CCC Live Cases because we have an absolutely legend of a guest with us today. This is Dr. Antonio Colombo, who really does not need any great introduction by me. He actually just informed me that he would be changing his roles. I'll let him describe that in detail. He's going to be the professor at the Humanista Institute in Milan, and of course before that we had known him to be at San Rafael. I really do not know whether we would even be stenting today had it not been from Dr. Colombo's work or using dual antiplatelet therapy, which in my mind has been his biggest contribution to interventional cardiology. The management and recognition of stent thrombosis, the areas where Dr. Colombo has made a difference, it is absolutely unbelievable. Dr. Colombo is also the visiting professor at Columbia Presbyterian and the recipient of the TCT Lifetime Achievement Award and of the PCR Ethic Awards. It's an absolute pleasure having Dr. Colombo join us. Antonio, welcome.
Okay, thank you so much. Thank you for Samir for the very kind words. You know, we try to do our best. We are passionate about what we do. And we like to continue to do what we do. We learn from others, we teach to others. Is a wonderful community and is a privilege to be part of this community.
Antonio, we honor you and celebrate you. As far as I'm concerned, truly coronary stenting would not even have been there from the moment. I don't know whether it was 1993 or 4, maybe earlier when you first put in the ultrasound in the GR stent and taught us so much.
Yeah, I don't remember anymore.
Yes. Antonio, happy to take you to the cath lab, and Dr. Sharma and Dr. Kinney are standing by, and they will also additionally welcome you and take you through the case of the day.
Thank you.
You say?
Yeah, good morning, everybody. I just want to start the introduction welcoming Dr. Colombo to our CCC live cases, but you know, every time we just talk about ourselves, these cases could not be done without the help of our staff. So today I'm taking just a few minutes to introduce our staff. We always, at the end of the year, you know, introduce our interventional fellows who rotate through room 2. Today I have Akash Garg, who is an interventional fellow. I have 2 who is an interventional fellow. And Pablo probably has done, focus on Pablo please, has done probably most of the live cases here. And I have 2 of my great nurses, wave at them, Will Tan as well as Mark. Yeah, these guys are the backbone here. I know we are doing the procedure, but they manage the patient from behind. Dr. Sharma.
Great. So, Antonio, welcome. And as you know, the format will be the same. We are going to present the case with some history and do the active case performance. And then in between or end, I present 2 topics of interventional interest. So what we also learn, you know, same thing as you said, we learned ourselves. So we saw our fellow 2 is making a special another the app with Dr. Keeney in terms of the wires and complex angulated discussion. So what we found is that we kind of swayed away from. So case, what we will do, that 1 minute or 2 minutes description that what we are going to do after the angiogram and see whether that is done. So that I will ask Anu to make that statement that what is your plan of the case today. So with that note, if we can start, let me just start the first few baseline slides and then we go to the NGOs. These are our disclosures. And of course, welcoming guest faculty, Dr. Colombo. This is the case number 138. 75-year-old female, we have new onset of angina, positive stress test, SAQ. As you know, the SAQ, higher the score, less troublesome is the patient. We have published a correlation of SAQ with the CCS class. So patient has SAQ of 75. When came last time, this time actually is like 95. So has done very well after the RCA intervention on good medical therapy. RCA PCI was done, and today is for intervention of the angulated LAD, which we are going to describe. We have done the baseline shot. In this patient, still has mild angina, and the residual syntax score is 15. So plan today is basically the PCI of extremely angulated calcific LAD diagonal, angulated mid LAD diagonal bifurcation lesion, likely will require some angulated catheter for wire advancement. And as we do all the time, these are the 3 angulated catheters available in the market. One is the Supercross, which could be anywhere from 75, 45, 90, and 120, and the XT even further than Venture, which comes over the wire, or monorail. The both are kind of make you angle about 90+%, and the which is not available in America is Swift Ninja. So with that, our in terms of appropriateness, which we always our hallmark of every case which we do, this patient has an intermediate risk finding, non-proximal LAD involvement on 2 anti-anginals, so appropriate for intervention. So now Anu will take us through what they have done with the angiogram. We go to the fluoro again, please. Good.
So EDP was 12. If you see the LV gram, normal LV function, patient had right coronary artery stent, which looks good. This was a Xience stent, and this is where we are. Left main is non-obstructive, and we do have, circle like a moderate 50% in the LPL, but this is where the today's case is of the LAD, mid LAD, 90-95% lesion. Then there is a large diagonal, and just at that level, which is mid to distal LAD, is another 90% lesion, which is angulated, almost, I would say, about 70-degree angle that we have. The wiring this LAD is probably the key in this case.
Okay, so tell what is your plan? So we need to, and then we'll ask Dr. Colombo that if this patient is in his lab, how will he do it?
Yeah,
so what is your plan today?
To use any of those 2 catheters that you have shown, whether it is Supercross to get into the mid to distal LAD, or even the Venture. A Venture comes in 2, or the wire, or a monorail. We should be able to, manipulate, rotate this catheter. Significant mid LAD lesion is not allowing us to do that. So what I plan to do is just wire the LAD into that large diag, which is disease-free. Do PTCA and stent the LAD just after the septal way down. Then we'll try to see if we can wire without any of these angulated catheters. Otherwise, I think I would start with the Venture first.
Okay. All right, let's start doing. And Antonio, we need your opinion now.
But I think you can use a 6 French guiding catheter, radial approach or femoral, whatever you feel more comfortable. My first wire of choice will be a Fielder FC. The problem here is to cross the second lesion. I will try to advance and prolapse into the second lesion if I can, making a big J. And if I cannot do that, and if I have this dedicated angulated catheter, certainly will be perfect. I really want to advance the wire distally, and I don't want to dilate the proximal lesion without the wire distal, because sometimes you may induce a spasm even if you don't touch the lesion. and that gives you trouble. So
Okay.
before doing any balloon maneuver, you have to have the wire advance.
Advance.
Stenting, I don't like to stent this angulated lesion, but there's nothing else like you can do. I think one stent will be the way that the diagonal is fine, and I think it doesn't need to be stented. One single stent, ideally a very thin struts, a flexible stent will be the best choice.
Great.
All excellent recommendations, and Tony will keep you involved as we make progress. My personal choice would have been a whisper wire to have started the. You may luck out and it may cross, but let's see.
Good.
XBU guide 6 French.
It's a
Mark
Mark.
Trio.
Okay.
We
Mark
use
Trio,
all
yeah.
our the Mark guides. They have actually another little stiffer one, runaway,
Right.
but we don't use that. But Mark very soft guide. So that's our guides in our lab. We do have some 5 French or Metronic Sherpa guides. We traditionally don't use those EBUs and so those curves because we found them a little more stiffer. But
Right.
some of
Okay.
my
You
volunteer
want a guide
attendants do
shot or
use.
no?
Huh?
Guide shot or
Yeah, take a guide shot now. Yeah, we give nitro and we are taking the guide shot now.
Dr. Colombo, would you be
Yeah.
doing this radial?
I will do radial. We now switch to radial 90%. Of course, nothing wrong to do femoral.
Right, absolutely.
But,
What do you want to do?
Keep going. If we can, we do radial.
Let's try to wire the distal segment first. Let's try without anything, right? Or you want to go over the wire system?
Antonio, what does this tell us about the new institution you are going to be joining soon in Milan?
Otherwise, we keep it that way.
The new
Try, but
institution
try
is
one
the
time.
University
That's what I'm saying.
hospital with a nice medical school. They have
What
even
balloon
an
you have?
English-speaking medical school.
We don't have a balloon.
Yeah, get a 2.5.
I will
Trio, no?
work with the cath
LED.
lab
3 or 12.
and being
No, 15 SS.
professor in
Look
Okay,
at
3
the
or
line.
15. Yeah.
all the people that work there are my trainees, so it's for me to go home.
I'm not at all surprised.
Everybody there, including the chief of surgery, the lady that was on training when I was in San Raffaele. So it's
You're not planning to slow down on your interventional volume, is it?
no, absolutely
Okay.
not.
Not to go to
And
bottom
I will
first.
still
I
be
think you're in a
working
different
in
branch.
Columbus.
No.
I thought
You're going
maybe
to
a
do-
little
Okay,
more
yeah.
skiing and a little less interventions, but then that is not you.
Yeah,
Not yet. But Colombo is very young yet.
interventions.
And you'll be visiting New York often?
Yes, I still maintaining my position at Columbia. I did all my online courses, etc., vaccinations, everything.
Wonderful.
To maintain
Uh,
privileges.
Antonio, what is the status of the vaccine? Has it been approved in Italy?
As is approved, they say that the January 15 they will start with hospital employee.
Right.
I hope
Very
so.
good.
Either I think I'm going to the
That's
small
the
branch.
Pfizer or the Moderna?
Pfizer.
Excellent.
So
Yeah,
which
we will-
wire are you using now?
Yeah, Whisper.
Fielder.
Oh, sorry,
Some die.
Fielder. No, you're there.
No, some die.
Yeah.
Fielder
I
FC.
like the
Yeah.
fielder.
Good.
Okay.
Yeah, it's a regular fielder. So we actually, we are now, see this, now this is,
It looks like it's going,
Yeah.
but no.
no, as pointed out, the proximal lesion will prevent further progress. So if you want, we can go with the, you want to
Fielder
go?
FC on?
No.
I don't know.
No, I would just go with the, you can try Fielder FC. And the other question is then go with the exchange length and go with the venture.
You may also
Yeah.
consider leaving this wire in the
Yeah.
diagonal
Right.
Right.
as a
As
marker so
Yeah, leave it
you
there.
know where you should not
As a-
go.
body wire. Huh?
Fielder FC, okay, right?
Yeah.
Yeah, Fielder FC. Okay, so now we're leaving this wire. So clearly we are protected with the proximal lesion into that diagonal. And the whole question comes at what time you switch. I think as pointed out, we did have a discussion about what is the right strategy. Do you stand first or you go to the distal? So I think if we should give a little effort, little time to see if we can go to the distal lesion without opening the proximal first. But yes, if there is any difficulty, decreased flow, and so it's easier to put a stent. We are ready with the balloon, and then we'll put a 3.512 Xience, and then we go to the second one.
Not 12, you need longer, 18 maybe,
Yeah.
SS.
You need torquer on this?
No,
Balloon?
let's see, no.
Okay.
I'm glad that you are transmitting in wiring, because the wiring
Yeah.
is a very important part of this
Yeah.
procedure.
So Antonio, there is a doctor, I think from India, Dr. Ritu Bhatia. She's posted her first comment, agree with Dr. Colombo, wise to wire the LED before dilating.
No, absolutely. Only problem is many times it is difficult to move
To wire it,
once
yeah.
you have very significant lesion proximally. So that was the logic behind initially that we will do, because we have seen once you have very tight angulated lesion, then your second angulated lesion, your things don't move even with the using those angulated catheter, because once you get angulated catheter, vessel shuts down completely. You'll have no flow.
Maybe you can pre-dilate the proximal lesion with a gentle balloon like
Right.
2.5.
Yeah.
Not
No.
Huh?
No,
Then,
that's a plan. That is what we had
So let's
planned,
do it
that will
now.
dilate the proximal lesion.
Yeah.
Likely once we stent it, I'm telling you, it will be 2 minutes, 2 seconds to cross that.
Yeah.
And
So let's
the
just-
other possibility, of course, is to use a dual lumen catheter and give the second
Twin
wire
pass.
a very pre-shaped sharp turn,
Yes.
90
Right,
degrees.
right.
Yeah, yeah. So that one or the angulated catheter, we have very good experience with all of them. All supercross usually 120 or venture. So we have good.
Oh yeah,
So-
the angulated catheter, if you can afford,
Yeah.
these are excellent.
Yeah,
And,
good. Go.
Are you sure you're there? Don't make sure that you are across
Okay.
that other lesion.
You see that just
Yeah.
by putting the balloon,
Okay,
the
now you go.
2.5 balloon, that flow closes. Okay, we are going up.
Yes. Okay, down.
No,
Yeah.
moved. It's scored back. Ready?
Mm.
You want to get a 12?
Let's see here.
Okay.
Otherwise, then
We are
go
going
to
low
12.
pressure. It was low actually. Now we are going to go slow.
Okay, good.
Yeah, good. Got there.
Okay.
Yeah, 6 atmosphere.
Okay, down.
We
Okay,
just
good.
need some room.
Yeah.
Should we just go with the venture?
Okay. So do you
I would
want
still say what I
additional-
meant is will PTC and will have trouble. Okay.
What do you want
What,
now? You want to take a
okay.
picture?
Okay, take a picture and
Good.
we make a quick decision.
Yep.
Venture or no venture.
Good.
So for looking
Okay,
good. So give
looking
me
good.
over the wire venture with the, I'm going to leave this wire
Yeah,
there.
Right.
So Samin,
Exchange
20.
length.
So you understand because of the dissection.
What's
Suppose
here?
this wire
Yeah,
comes
we can-
back. That's the
right.
reason I
No,
wanted
leave
to
this
stent
wire.
it.
No, that's fine. And we can take the, you want to,
Because it may
which
take
over
time.
the wire you need. To me, I think,
No, this is over the wire you gave
yeah,
me?
yeah,
Oh,
you said. Yeah, that's fine.
So Samin, 20 years ago, it was for these lesions, you were using Epsisimag.
Yeah.
Now
Run through.
you
Over the wire,
gonna
run through,
think
right?
that I'm,
fielder again.
Okay, fielder long.
Oh, we have fielder FC, right?
No,
No, get me
exchange
fielder.
length. Exchange length fielder, yeah.
No. Regular fielder.
Can I
No, but
tell
then you're
you?
going to change again.
Yes, yes.
Can I tell you something
Yes.
crazy, guys?
Yeah.
Yes.
Okay, please try to forget what I tell you, but for a moment, let me tell you.
Yeah.
For these angulated lesions, I
Flush.
am very nervous to stent because of the high risk stenosis.
What do you do?
What I do pre-dilatation, not super aggressive, but good pre-dilatation. I leave a pressure wire distally. I work on 2 wires, one pressure wire and one regular wire. And after pre-dilatation, if I see that I have a residual gradient stable less than 10, I just use drug-coated balloon and not stent.
Okay.
All right.
Well, let's make it a little simple for us that drug-coated
Yeah.
balloon are not available in US yet.
But
Full back.
I've been doing these on selected lesion, only on lesions that I consider not ideal for stenting for the past 2 years.
Your other wire has come back.
That's
Antonio, how
exactly the
has
reason I
how
was
has
telling you
been
to stent
the
it. Now we
long-term
we lose everything.
outcome of
Very
these?
good, very good.
Very good.
I'm
Excellent.
doing follow-up.
You
When I
understand?
have
Caudal
a
again?
large
Yeah,
case, I'm gonna
that was
publish
a
it. But I think is still something to keep in the armamentarium. I
Right.
don't want to go against stenting, but consider that stenting may not be the default approach for every lesion.
Right.
Yeah, and particularly the drug-coated balloon in the smaller vessels. I mean, it's a very large vessel. My only question will be, in the large vessel, that even you have a good FFR negative post-procedure became 0.92, would you be happy with this?
If
Because of the
I
large
have
vessel,
to
yeah.
place a short stent like here, I will use a short stent, no
Put this one back
problem.
up.
I use the approach that I just told you when I have to implant long stents,
Ah.
especially in the LAD, mid LAD and stuff like that.
Antonio, you get access to a lot of newer technology. Anything very exciting and innovative you're using for such angulated lesions? More
Nothing,
steerable wires, deflectable
the
catheters?
wire that you have are the same, the one that we have.
Good.
Nothing.
Tell me when you want to.
some die, so I know.
The only thing that
Pull back
we
the wire.
have is drug-coated balloon, and we
Yes.
have a Limus-coated balloon, that the one that we use nowadays. We use Magic Touch or Solution from Switzerland.
Now, what has been your experience with the paclitaxel versus sirolimus-coated balloons? I know there are a lot written in the literature that people are going
I'm not
more for the
afraid about
sirolimus.
this business of mortality. I think this is overemphasized, but definitely new technology, Limus, has a lower late loss
Some die.
and it's much better. With the Limus coated balloon, you can afford the late loss of 0.2 versus 0.4 with the paclitaxel. We are doing some randomized study to compare
You want to put a stent proximal? That's
paclitaxel
fine too.
versus
Okay, now die.
Limus.
Cine?
Mm.
Mm,
So this is the venture has made a 90-degree turn at that level, but it's not at the ostium yet. I think we need to take a good cine because it need to be ostium. Because once it is at the ostium, your wire will go.
Yeah. Sometimes you should also look in another view because
Right, right.
may point right in this view, but maybe in the different plane.
I think we take a cine. Okay. Aleocranial, then go
Okay,
to
that's good.
aleocranial.
No, this is a good view.
Okay, take a cine. So we know that you are at the ostium. Okay, I'm starting. Yeah, so make one more
Exactly,
curve.
yeah.
Little more clockwise turn. No, make a slide more clockwise on the venture.
It is not. Oh, damn.
Yeah, good. Now it will go. Good.
See, we went too much.
Okay. Little undo.
I think I need orientation better.
We may have to go back to the same strategy what Anu earlier said, that we stand the proximal area, make it a little more movement of the devices easier, and then go back with the venture.
Super cross maybe no. Okay, we'll see venture. Yeah. Oh, right. Some more die.
Okay.
So, I mean, so far as the teaching case is concerned, this is just a excellent case to demonstrate.
Yeah, so this is actually picked up by Anu. She said that let's show some more tortuosity than our classical run-of-the-mill calcific bifurcation, rotablation and all. So this is where it was her case. We did the PCI of the RC a few weeks ago. and we brought back. Usually we wait for 1 month, but we thought it's a great teaching case, but significant lesion. We could not have waited till mid-January, so we brought the patient now.
Some die again, sir?
Okay. So to approach Anu now, that either we put a stent, as you said, because remember now you cannot see any flow distally.
Let's stay
So that
put
is
a
okay.
stent and then maybe change the
Straight
catheter.
the tip.
Yeah.
When you take the venture out, you have to straight the tip again and advance the wire. Otherwise, you're going to scrape the vessel wall. 1 second, and then you take it out. Okay, good.
Got it. Very nice
Keep holding the
demonstration.
wire. Yeah. So good. You want to take a picture and select what stent length you want to do?
Yes,
Okay.
let's do that.
Good.
Okay.
Okay, the flow is still good
Yeah,
enough.
it's still good.
Antonio,
We can do a
what
3.518.
would
Not till
what
5.
Huh?
what
3 to
would
5
be your
3 to 5.18.
anticoagulant
I would
strategy
say,
in
sir.
this case and even otherwise?
Yeah.
You're at heparin or
And after that, we
bivalirudin?
know it will stay okay.
No, heparin. We don't use bivalirudin at all.
Right.
Bivalirudin is out of the...
Using some cangrelor?
Some... can you repeat?
Cangrelor?
No,
Not.
we only using some acute coronary syndrome when the patient is not being preloaded.
Antonio, as they are making progress in the case, a few other questions which I think the viewers kind of would be interested. What is the composition? Structural heart is what percentage of your cases now?
I would say 20% structural. We do aortic TAVI, which is now almost over the counter. We do mitral clip, and we started tri-clip
Right.
on the cuspid.
And
We have a research protocol with Ancora, which is like LV remodeling.
And for TAVI, what are you using most of the time, Edwards or
Most of the time,
Corva?
in private hospital, we use Sapien.
Right.
For cross
In
also?
public hospital, we use core valve as a primary. Because of
120.
the
It has to be
price.
120, and you are the long fielder anyway.
Sapien or
Now
me
take the wire out,
valve,
balloon out.
but,
Okay.
there is a special indication, but we need to motivate, give a reason why we don't use the core valve.
Right.
Good.
No,
They-
no, believe me, we think it is going into the LVEF.
Yeah. Yeah. We've been
Now,
fooled.
only other thing I was thinking, SS, we may have to go with the Miracle 3 or something.
No, but let's go with the. If the question is 180 venture, I mean the venture of again, or you want to with the Supercross 120.
I think fine cross with the Miracle 3 with the. Okay, some die. We can try Supercross.
Yeah, looks very.
Yeah.
See that? It is.
I would go back with the venture again.
Okay.
Take this balloon out. 1 second, no?
No.
No. Take this one out. Take the balloon
I'm
out.
just telling
Go
it-
back
it
on the
is-
venture with the same.
I think it is telling us the wire gets to the
I know. but
ostium and it just flips
venture,
out.
yeah. So that's the venture. What the beauty of the venture is, it gives you the back wall support. So that's why many times I like the venture better. And key is that even if it comes at the ostium, wire may not go. So what venture and those will give you a backline support. Get back the venture again, or but it's over the wire now. So
Sorry.
let's decide what we need to do. We need to get the new equipment now. Yeah.
Samin, another very interesting question. I'll read it. This is from George Sitafides. He's recommending, what about the use of a dual lumen microcatheter with
Yeah.
the Xience
Twin
wire
pass.
and a sharp tip curve?
Yeah, twin pass. Yeah, so no,
All-
people have
all-
used the twin pass also.
yeah.
Yes.
All good recommendations.
This
I
will
think
not
the
work.
Tell us
Xience
then
Waste your
what
time.
do we know.
Okay, then get me just
Xience
find.
is a super steerable. Another wire to consider is a Fielder XTA anterograde,
Right.
which is tapered, very soft, may navigate with flow.
Samin, a question, a recommendation
skin
from
flush.
Dr. Jaffrey from Singapore, Supercross 120.
Yes. So that is exactly
all-
our, that would have been our plan.
Right.
Always had been throughout the Supercross 120. So we just wanted to see whether venture makes any difference and so, but it's just Supercross 120 with angulated. Keep
Want
going.
to try a Supercross 120?
Huh?
This is only I'm saying.
No,
This
but
is
you
the way
need,
it will
yeah, but
cross.
that's no, but you need to then go leave this one over the wire system with Supercross 120 we have.
You have a Supercross 120?
Yeah. We have Supercross, but this has to come out. Usually, Supercross, you cannot put two wires with a Supercross because it's very tough to advance. So only one wire.
I think with having put the stent there, now you have a better situation to use a single wire.
Yes.
Antonio,
What
what is...
I am recommending is a fine cross and a Miracle 3, but let's do all the other recommendation first before I do what I think would work.
Yeah. So basically, we are going with the Supercross 120. That was the plan. So we just, again, the venture success and that how venture works out is a little plus minus many times. What I'm saying is very simple. Why don't you go with the over the wire this system?
Samir, can you explain for the audience what is the Supercross 120?
Okay. So let's go back. If we can go back to the slide.
Where we can show the Supercross.
Yeah.
It
Go
is
to the
over
slide
the
now.
wire, and
So-
or you show the box also,
Yeah.
where we can see.
And we can show the box as well as those are the, go back to the slides, please. And we have the box there. Yeah. So this is the
we
one.
see it very nicely.
Yeah. So these are the various types available: 45, 90, 120, and then special XT. Which don't carry it. We only carry 90 and 120. So basically, it's a fixed wire compared to the system that compared to our the venture,
Advanced wire.
which venture can be make the curve while inside the
1
body.
second. This is what I don't like about
Very good.
that.
Okay. What do you want to do?
Wait 1 second. Pull the wire back. I think the tip is gone again.
Samin, just
change
to
the
Okay, go.
remark,
We have to change the wire.
Yeah.
remark
It is-
on the slide you've just shown.
Yeah.
I think it's amazing. Teleflex is a company dedicated almost with the multiple
Did you take the wire?
devices
Yeah, change the wire.
for angulated lesions.
Wait.
Yeah. Yeah. That's right. Yeah.
Hold it.
Yeah.
But the tip you have to change.
If there,
Way further.
once you go, you can use your Miracle 3.
No, then I'm not using Miracle 3. You can try with Fielder first.
Okay, we are short fielder.
Give me that. Take this out.
Yes, but make a cover on the short fielder first, then we take it out. Yeah.
Miracle 3 is ready?
Yeah.
Okay.
So this is the fielder that we are trying
Yeah.
now.
We are taking a, we're trying
Do we
Fielder
have
first.
a fielder XTA? We used to carry it before. We have it, so bring it. So we may use that. We do have. I think we use maybe one per year, and this is the today's. With Antonio's advice, we have the anti-grade. We don't use this somehow.
Can
it is
you
not
show
a
me some dye
wire.
here?
Yeah.
So we know we are exactly
Okay.
there. Wait. Let me get in.
So Samin, another,
far.
a lot of viewer participation today, and I want to encourage that. This is Dr. Mansoor recommending putting a balloon there, occluding the diagonal, and then trying to cross into the LED.
Okay, let me tell you that point. The eye, in my lifetime, that
Never
strategy
done.
I have tried 10 times, and
Always
last time
failed.
was 10 years ago, and 10 out of 10 failure.
Okay.
That did not work.
I agree. I tried
Yeah.
5 times
Yeah.
and 5 times
So,
failure.
so Dr. Mansoor, here it is 0 out of 15.
Personal experience. I mean, I'm sure one time or so it
Yeah,
could
yeah,
work,
yeah,
but I'm just saying our personal experience.
If
What
we
do you
keep
need
doing
now?
this, vessel will close.
Okay, what do you
My
need?
personal experience
Okay,
has been
now you
better.
see, let's teach it. Go. Take Cine.
Okay.
Okay, good.
Probably need to advance a
Yeah, little advance, and
little bit.
actually she's thinking, Anu thinking to use a miracle, little stiffer.
If you have seen it, you see this floppy tipped wires, they're just getting deflected.
Right.
So let me take a
This is
Cine.
better,
Hold
yeah.
on.
Yep.
Do not inject. So what's happening? It's getting there.
Okay.
I'm probably getting deflected
Just a
again
little
because
dye.
it's a significant lesion. Okay, some dye. You want to give some dye.
Good.
Okay, we are there.
Yeah,
okay.
it will go now.
In-
No, I'm not sure.
That's
Inject.
where it deflects
Yeah.
into the.
Yeah.
Okay, now we've
No,
made.
but now it
progress.
will. Yeah, it will go now. This is the first time went that far. Yeah.
Okay, there you go.
So we needed a super cross 120. That was our strategy. Now it's in the septal.
Some dye.
Yeah, now in LED. Yeah,
LED.
good.
I think now
Yes.
go in another room.
Okay.
Good.
Bye-bye.
Good. Okay. Now we need a extend and
300.
run through.
No, we had 300 fielder or you want to run through?
Run through. Run through.
Run
That
through.
damage.
300 run
Yeah,
through.
Yeah. So now we have to put over the wire system. While we are changing, everybody agrees. Saw the steps. 120 now. It's very nice. Bring it if your the fielder or XT. Actually, we didn't get to have the fielder XTA. Otherwise, need a little stiffer catheter. And the next one, wire. Wanted to go to the run to Miracle 3 or 6, but this worked out very well.
So what would have been if you had used Miracle 3 is a stiffer tip. It's a hydrophobic tip, not hydrophilic. These wires are all hydrophilic polymer jacketed wires. So, first you want to try this because you want to do atraumatic entry into this kind of osteums. If it does not work and you don't have this angulated catheter, you can go with a straight catheter. And then the good thing about Miracle 3 is it keeps the curve that you made. Because of the stiffer tip, it will keep the curve. Without angulated catheter, you could be able to, enter into the ostium of this angulated LED. Otherwise, we just showed you. Now, which I try to do with the Venture is that also, I know it's angulated and it's three-dimensional. You don't know, like Dr. Colombo was mentioning, go to another view to see exactly which part of the, LED that you have to enter. So you may have to go to one or other views, but we thought we could see it well in this areocranial view. So what you need to do also is you have to rotate. If you can see my fingers, you have to rotate clock, counter clock. So in three-dimensionally, you are able to get into the vessel ostium into the right place. So you got to clock, counter clock with your left, and with your right, you are making movements with the wire so that when you're at the ostium, you're entering into the vessel. The same thing other way around. Could be that the angulated diag, that you have to enter the angulated diag. Yeah.
Now also, once you
Some
put
diag,
this super
make some
cross, they're very stiff, to take out. So make sure that you're holding the wire, looking at the tip of the wire. Usually many exchanges we do without fluoro, but this one I would suggest to be on fluoro, because otherwise by the time your came out supercross, your wire is back.
in particular, because some of these are hydrophilic wires, and
Yeah.
yes, they would perforate. Anu, several emails complimenting you on the technique of crossing into the
Balloon
diagonal
again.
there.
The trio balloon again.
So now, ideally, we should be like what Dr. Colombo mentioned in the early part, that try to do it, which you saw, we tried to get into the LED with the angulated catheter, and to go with more aggressive wires with the significant lesion, we were not able to, rotate the angulated catheters. So we dilated. Once we dilate, then there is a dissection in the LED. So you're very cautious, thinking that if that LED, develops slow flow, then we will lose the diagonal, which is a large size and did not have any disease. So because of that, instead of coming out with one stent, we will now have to have two stents.
Yeah.
Very pragmatic decision to stent the proximal lesion.
Yeah, we actually, Antonio, we have this kind of situation many times in the past. Once you have such a tight lesion and then second lesion is angulated, we always have a trouble. Reason is that as soon as you engage the proximal lesion, you can't see anything distally.
Down.
So if there is a landing zone, in this case, actually, we were very good that there was a landing zone. Many times there is no landing zone, then you're real deep trouble.
Okay, go up now. I
Okay.
think we didn't dilate well.
Yeah. So here,
Trio.
angulated has not been dilated well. Now we are going to, it's okay.
What
Well
size
atmosphere.
balloon is this?
It's a
What
trio.
size-
Trio.
3 or 15.
So you want to put a 3 or 18?
Yeah, we can get a 3 or 18, right? Get a 3 or 18. Now, pull back, take a picture and see. Yeah.
Another question for you. Would you have used a cutting balloon there?
Yeah, in the ostium, if
yes.
did not open, yeah, definitely. Let's see.
Go.
We may still need to do cutting balloon, no, probably not.
Very
I think we
nice.
can just do a 3 or 18.
Looks
Yeah.
good there, yeah.
Yeah, or 15.
Now what length you want? From
Yeah,
where are you
15
going to
will be
stop?
okay. No, at the septal, early the bulge. Don't go further down.
But your
15 or 18. What do
your
you think?
balloon went there.
Yeah, that's fine. I would say 15, 3 or 15. Okay, so while we are deciding, putting a second, this is the
3 or
simpler
15.
point. And we can go back to the slides, and in the end, we are going to show OCT. The latest, the new OCT equipment, catheter has arrived. So we are going to do the OCT in the end. So with that note, we can keep just going through our slide presentations as usual. And Antonio, in our CCC live, we just do one case. I know that I catched, followed your the last sentence that go to the next room. There other rooms are, but in this we continue to have all the educational point. And for the CCC live case,
No,
we just
what
do
he
one.
meant next room is case is done.
Yeah.
We move on. And, that's what is yours. Yeah.
We like the joke.
Yeah.
We definitely like the joke.
It's good to do one case
Yeah.
and show from the beginning.
Beginning, yes.
Absolutely, yeah.
Yeah, that's it. That is the key. And actually, we can say now with the 11 and a half years, we did have some complications. We have our share of complication, small, but we never went out. We showed it. Only one case we went out after the initial issues, and then we showed to our audience later, and we actually showed that patient's good outcome at a follow-up interview a few months later. But yes, our goal always had been that whatever you see dissection, perforation, we have our share. So all those to be shown while on live. That's the key. So with that note, I'll go through our now this presentation, which we usually make 2 points. One, in terms of the trials, something which has come out, and secondly, the focused review of the month.
Okay, go up. I'm pulling back a little bit. Okay, go up.
So
Go up.
the trials of AHA, LVEF and CCS,
Down.
1 month DAPT, SCAT
No,
pilot,
that
these are all related to antiplatelet therapy, and the Pioneer 3. Then the focus review of the month is the clinical and anatomical predictors of long-term events in FFR deferred lesions. So let's start with the trials of our AHA. So first one is LVEF trial. Basically assessment of loading with P2Y12 inhibitor ticagrelor or clopidogrel to halt ischemic events in patients undergoing coronary stenting. An idea there is ticagrelor superior to clopidogrel for peri-procedural myocardial necrosis, done in the France and Czechoslovakia Republican PCI centers, and it was, as I mentioned, 1900 patient, troponin negative or moderately positive, with declining troponin, patient is scheduled for PCI, were randomized to ticagrelor, usual 180 loading dose and 90 twice a day, or clopidogrel 300 or 600 load and 75 daily, with 30-day clinical endpoint, and primary endpoint is release of biomarkers, enzyme. The patients has to have high risk feature, which is the patient related of the old age, creatinine, diabetes, and BMI, and acute coronary syndrome in the past, or low EF, and procedure related multi-vessel disease, multiple stents, left main, bifurcation, and venous arterial bypass. So basically what they found, that first the biological study, the platelet aggregation. So what it showed, that baseline you have very little platelet reactivity, means it was 98% platelets active, and by giving the clopidogrel, it went down to about 60-65%. By giving ticagrelor, it went down to about 15-20%. So platelets were really inhibited 80+% time, percent degree with the ticagrelor, and about 40% with the clopidogrel. So this we know. So physiologically made sense that yes, it was more effective. But what happened to the clinical? Primary outcome of the myocardial infarction, stent thrombosis, myocardial injury, exactly at the unity, no difference of the primary outcome, secondary outcome, clinical outcomes at 30 days. As you can see, the curve are exactly identical, overlapping. So basically showed, and of course, the what we basically found is much more side effects and minor bleeding, not the major bleeding, but minor bleeding higher with the ticagrelor, and the dyspnea causing discontinuation in 11+% of cases. So basically two negative for the in the LVEF for the ticagrelor, higher minor bleeding and more dyspnea causing discontinuation. So this basically was the conclusion of the trial. During the same time, second trial from Italy presented about the randomized comparison of intensified P2Y12 inhibition by using prasugrel compared to standard in elective PCI, which is clopidogrel. So clopidogrel against prasugrel, similar type of setup, elective patients, but less number of patients than what we have in LVEF trial, but 795, and basically found again exactly same outcome of death, NEMI, stent thrombosis, stroke, or urgent revascularization. And these are the individual endpoints. You can see all of them identical except minor bleeding again, higher in the intensified loading strategy of the prasugrel. So basically showed that these two trials, that now the way we do, so no longer forget the Triton, forget the Plato. What is the real life now at present is, particularly elective PCI, that clopidogrel is as good as the stronger P2Y12 inhibitors of prasugrel and ticagrelor, at the same time give rise to a lower bleeding and lower side effects. And so if you combine this, the pooled analysis of two trials, which are about 2600 patients, you see the BARC2 little bit on the clopidogrel side, but overall at the unity everything looks the same way as had been shown in those trials also. Now then question is the 1 month DAPT. Remember, most of the data on the 1 month DAPT has been in the high risk patient, but this is a study from Korea, not high risk bleeding patient, but both of them, high bleeding risk and non-high bleeding risk, 1 month DAPT in all comers patients. And the idea was that whether 1 month is better than 12 months or 6 to 12 months, and they use the biofreedom stent and compared to a biometrics or ultimaster in the second group, and continue DAPT for 6 to 12 months. And basically these are the individual, as you can see here, individual endpoints of the vessels and which were comparable except for the stent selection. And basically found 1 month DAPT was exactly identical outcome, non-inferior to 6 to 12 months. As you can say, it was not superior but non-inferior, hazard ratio 0.9 from 0.68 to 1.20. So exactly identical super added curves. And if you take after 1 month, because remember 1 month we stopped the DAPT, and you see exactly the curves still remain overlapped. So clearly there was no benefit of a continuation of DAPT, and these are the individual endpoints which have been shown here. While definitely the trend towards lower bleeding, not significant, but lower bleeding in the 1 month DAPT group. So now only one interaction which was found, as you can see here, age, sex, diabetes, hypertension, but key clinical presentation. Look at the ACS. 1 month DAPT event rate was 7.2, and 6 to 12 month DAPT it decreased to 5.1. So clearly significant interaction in acute coronary syndrome. So you can make it a point, that's the guideline recommendation, that you need to continue DAPT for 1 year. That is what at present ACCHA guidelines are, and particularly in acute coronary syndrome PCI. In stable syndrome, you can stop early. Then we went to further. What about you take away aspirin right away from the beginning? This is a prasugrel monotherapy asset pilot study in elective patients. What they did is patients, whatever they came on, they got aspirin, clopidogrel in the cath lab. You give prasugrel dosage, and then maintenance, no aspirin, no clopidogrel after, and they followed the patients for 90 days. There was 1 cardiac death, 2 peri-procedure MI in 200 plus patients, 1 revascularization, 2 minor bleeding. So overall seems to be the concept is very good, and they are going with a major trial now, that loading dose of prasugrel, no aspirin, and follow these patients for 1 year to see whether you have a lower bleeding event in these patients compared to giving the DAPT on so. So this field is going further. The last trial which I want to share, little exciting, before the trial was presented, and let's see we keep that excitement in the end, that was the novel healing targeted drug-eluting stent with synchronized anti-proliferative drug delivery to target smooth muscle cell proliferation after DS implantation in CAD. Basically concept was that you need to have a stent which can have a nice endothelization. And we know that the various the EPG capture the stentings, and so those all endothelial progenitor cells capture antibodies, and the nerve have not worked. But this is a new novel healing targeted called Supreme DES, which is the healing targeted DES by Sinomad, has a top coat, base layer, bare metal stent, and the idea there is that you have a permanent ultra thin polymer which really keeps the drug. And you can see very nice demonstration of endothelial cell movement. See, that looks very exciting. That you looks like that the stent has been with this coating, this combination, very healing should take place of the endothelium, so should have a lower event rate compared to the comparator. So basically, what we compare with the Supreme HT to Xience Synergy and Vision. There are some basic baseline data in the animals that favors, and then put to the trial of Pioneer 3 of a 2-to-1 randomization of 1,500 patient Supreme HT DES versus Xience Promus. Once you're ready for OCT, let me know. Yeah, not okay. Just 1 second. Then let me finish this. Yeah. So basically, we found the device success. Device decrease the trend towards lower device delivery, 97.3 versus 98.8, because of whatever the stent designs are, and endpoints are here at 1 year, exactly identical in both the groups. And then if you take to the individual endpoints of the target vessel MI or ischemia driven TLR, actually trend towards higher ischemia driven TLR. 1 second, we'll want to do live. And the overall endpoints were the stent thrombosis also was not different. So concept was endothelization may make some difference, really did not pan out in this particular trial. So with that note, I think we are ready to stop here because they are ready for the OCT after the stenting. Anu, tell us where we are. Yeah. Okay, go back to the fluoro. Yeah. Yes. So show the last picture first, guys, before we go to the OCT. No, how is the diagonal ostium looks?
Diagonal ostium is good.
Yeah.
Now
show the angiogram.
We are ready for the.
Show the previous picture.
Okay, we see it now.
Yeah, but we are not taking a picture. Yeah. This is where now, and then we are with the IVAS. There may be a little edge dissection distally.
Right.
Yeah. But anyway, they're doing a more sophisticated test, OCT, which can detect. Remember, I-lumen 3, that OCT detected more dissection than angiogram, although the expansion of the stent were not different. Minimum stent area was equal in the angiographic as well as OCT strategy. We give some nitro and verapamil and other things, or no?
Yeah.
There's clearly a dissection distally.
No, that's, remember okay. I made that point. You dilated distal.
Fine.
This
okay.
is just
fine. Okay, you are ready with the OCT, go.
Pressure.
Yeah, would be intriguing to see the distal segment.
Yeah.
Okay. So this is a new OCT catheter that we have. What they're saying is that there's improved crossability. Now the distal lens is 4 millimeter distal compared to the previous catheter. So we'll be able to get more of the distal vessel. And the proximal marker is exactly 75 millimeters. So we will know the pullback length. The lens has also improved. We are supposed to get a better and brighter image. So we are going to test everything right now.
What is the length with the new catheter versus the old one?
No, not the length. No difference.
No, area it will image. Same?
Same.
It's still same. Okay.
It's just the lens has gone distal. Yeah, better. You see that? It's nice.
Yeah, better
I can tell you the catheter is going smooth and nice.
Slicker. That always has done in intervention cardiology. The new things have become slicker than the first one. I think it looks a longer catheter. No? It looks longer.
Oh.
Maybe not.
Okay.
Okay. Kiski? Is good? You there?
Anu, this is your Japanese fellow, the designated
Kiski is my Japanese. He's
designated
the
OCT.
postdoc.
He does not have the microphone. He should have it.
Give a microphone to Kiski.
Yeah. Yep. Okay.
Okay. Okay. Ready, Kiski? I'm going to start now.
Fix the microphone better. Give it to him. No, wait 1 second. Wait 1 second. Let him get the
Let it play.
microphone. Yeah.
So essentially, he's doing a core edge. So distal marker, you put another pointer in the mid and proximal LED.
Let's continue. Confirm.
Can you hear him?
Yes, yes, we can. We can.
Yeah.
Okay. Okay, Kiski, start explaining.
Now correct distillation, doing correct distillation, accept. Okay, so now we can check from the distal. Okay, now this is the distal healthy vessel, a little bit plaque. I think a little bit of dissection here. And this is the distal edge, so a perfect apposition, no malapposition. I think not the distal edge dissection.
You see? No.
Yeah, no,
You don't see any distal edge
nothing.
dissection.
Yeah.
Yeah, and go to proximal. Looks a little bit protruding, but well expanded. And go to proximal.
Can you see? Shows the diag, exactly ostium of the diag.
Yeah.
Yeah.
So
Right
this
there.
is the diagram. Yeah.
Yeah.
Beautiful.
Yeah. See, it's nice
go
and
to
open. Yeah.
Proximal. More proximal.
Yeah,
I think,
Antonio, your comment on this?
This is the proximal edge. Yeah.
Yeah.
Perfect,
I
perfect
think-
apposition.
I
No
think it's
proximal edge
fine, the
dissection.
Show this.
dissection is very small.
Yeah.
It's not compromising the lumen at all.
Yeah. Yeah. Yeah.
Beautiful.
No. I want to show that entire 3D stent.
Antonio, leave it distally alone or
Okay.
put a balloon there at a low pressure.
No, I will
Just leave it
Leave
alone.
it alone. Yeah.
Okay.
Now look at this. Look at see just an overall view where you have seen the stent opposition. You see there just few red dots. That's it. So which is an acceptable result. And here Kiski showed individually every segment, which is well opposed. And going back to the dissection, I think we are okay even based on the OCT dissection where your angle should be more than 60 degree. We don't see anything here.
Yeah.
Or if you see a dissection flap, the length of the flap should be 2 millimeters or longer, or it has to go deeper. Then it has to reach to the deeper than media and adventitia, not just intima. These are the 3 OCT criteria. If you see on the dissection flap, that's the only time you have to stent it. We don't see any of that here. So I think based on the imaging, everything looks good. We will take a final picture now.
Okay, good. So very good. Let's complete while we are finishing the last picture. Go back to the slides, please. Excellent demonstration and excellent picture. And let me just quickly go to the last point, and that is the clinical and anatomical predictors of long-term events in the FFR deferred lesion. As we know that what are the features? So we know that patients, we don't do the PCI because FFR was more than 0.8. If you follow them, these are the 5-year data, and then the angiographic, the parameters and the IVUS, they did IVUS in these patients, adverse coronary clinical parameters and adverse plaque parameters, MLA, plaque burden positive remodeling, EF less than 40 or diabetes mellitus have shown a subsequent predictor of event. So basically, whether patient related or the lesion related, vessel related, clearly the positive remodeling, plaque burden and LVEF and diabetes associated with event rate, which occurs in about 8 to 10% of cases. And it is cumulative. More features you have, higher is the adverse characteristics, higher is the event rate at follow-up going up to 40%. And if you take angiographic, clinical or plaque related, if you are none, event rate is 4% at 5 years. If both are present, it's 21.3, and seems to be that we have some way to predict which patient is going to get into trouble. And it seems to be that the combination of the plaque burden and lower MLA is associated with a bad outcome. And all these features are cumulative. So seems to be that in patient with FFR guided deferred lesion, 5-year clinical outcomes were excellent. Lesion-related anatomical factors from IVUS imaging as well as patient-related clinical factors could provide incremental information about the future clinical trials. So they have very nice editorial about luminography to physiology to the plaque morphology. So now sum it up that what did we learn from the trials? Clopidogrel better than ticagrelor or prasugrel, stable CAD, 2 thumbs up. Pressure without aspirin stable CAD PCI, 1 thumb up, and healing targeted DES, I would say no advantage of that stent at all, rather maybe problem in terms of advancing the stent, higher device failure. Yeah.
I mean, really good review of the cases, but not really much surprise there. We've never really expected any of the newer agents to show difference in stable CAD.
That's correct. So now 5-year follow-up of the FFR deferred lesion showed overall low rates of patient with lesion-oriented outcome of 10%, clinical factors like diabetes and low EF, along with anatomical features derived by IVUS, which is the MLA, plaque burden, positive remodeling are predictive of follow-up events and are additive in prognostication of the follow-up events. Since PCI is not indicated in these lesions, aggressive lesion targeted therapy of reducing LDL, raising HDL, sorry, it should be typo HDL, and anti-inflammatory drugs should be intensified. So 3 questions regarding the recent randomized clinical trial comparing ticagrelor or prasugrel versus clopidogrel, except overall MACE rates are similar in 2 groups, overall bleeding rates are similar in 2 groups, stent thrombosis rates are similar in 2 groups, minor bleeding events are higher in the clopidogrel group, and periprocedural MI rates are similar in 2 groups. Clearly, we learned that the minor bleeding is lower with the clopidogrel without any difference in MACE. Then 1-month DAP trial comparing 1 month versus 6-month DAP showed the following: similar outcome in diabetic versus non-diabetic, similar outcomes in ACS versus stable ischemic heart disease, similar outcomes in males or females, similar outcomes in multi-vessel versus single vessel, and significant CAD versus no CAD. Clearly, we saw that short-term DAP has an interaction with acute coronary syndrome. 1 month is bad for ACS PCI patients. The last question: following are the clinical and anatomical parameters independently associated with long-term MACE in FFR deferred lesions, except diabetes, EF less than 40%, vessel type, MLA less than 4, plaque burden more than 70 on IVUS, and we learned that not the vessel type, these are other 4 factors which contribute to the outcome in the future. With that note, we finished our presentation and we go back to Dr. Keeney to make the final comment. Yes.
You're on the wrong camera.
Anu, also as you make the final comments, just comment on one of the viewers observed that the flow in the diagonal seemed less. I didn't.
No, we have multiple pictures at the end.
Right.
You can see it.
I didn't think so at all.
No.
And also
just here. Look at this cranial picture.
Right.
Yeah.
Either you or Dr. Colombo can comment on 1 versus 2 stent strategy. They're just addressing some questions.
Yeah, so going back to the point here, if you see the flow we did give at the end after OCT, gave vasodilators and took multiple views. The best view I think is the same, the cranial view. You go back where you can see right there. Go back to the cranial view, stop there so we can decide why we did single vessel versus double vessel stenting. No, previous. Yeah, stop there. So the diagonal, if you see, was a large size. It's a 3O vessel, but there was no osteal disease angiographically. So when you make a decision, when you want to stent, which is a single vessel, we always teach provisional is the way to go. If your vessel size is less than 2, you don't even have to worry. 2.5, maybe you want to consider something. But in a large vessel like this, you have to be very cautious. Once, if there is a plaque shift, that's the time you reassess and then make a decision again. If there is a plaque shift after you've done the main vessel stenting, consider maybe balloon of the side branch. And if there's no plaque shift, just go ahead and stent the main vessel. Now, if there's plaque shift, you balloon the side branch, still there is disease in the side branch, which we are talking more than 70%. Everything is nicely described in Bifurcate app. If there's more than 70%, despite you doing a PTC of the side branch, that's the time you'll consider, I will do 2-stent strategy. Now, going back to what is the best 2-stent strategy, the various techniques that has been described, we are proponent of, mini crush technique. A lot of people want decay crush technique or culotte. whatever you want. What I try to tell you is you master one technique so that when the time comes, you know how to do the steps 1 to 3 without any problems. So here we do mostly mini crush and maybe few cases decay crush. Then comes the equation, what is the guide size you have? If you have 6 French, your radial, like Dr. Colombo said, you may want to do decay crush technique if you decide, okay, now there's plaque shrinkage into the diagonal, there's slow flow, something has happened, then you do decay crush where you stent the side branch first, then you crush it, recross kiss, then you put the main vessel stent, then you do recross kiss. If you have 7 French, now here we were very confident that we will, the diagonal flow will be okay and will not have issues. We went with 6 French, knowing that we will stent across. We wanted initially, ideally, if we had got into the LAD just by our initial technique, yes, we would have done 1 stent from mid LAD to distal LAD across the diagonal. But since we knew, because the proximal, the mid LAD lesion was so tight, we were not able to navigate and rotate this angulated catheters. We had to pre-dilate so much, so we had to stent it so that area of the LAD is stable. Then we can focus on the angulated mid LAD lesion. And once we did that, diag all the time was rock, what I would say rock solid, did not move. There was no plaque shift. There was no issue in the diagonal, so we decided we stent across. Finally, the imaging also showed us, we showed you the ostium of the diag. Now, there is, studies to say it, if you need to see the ostium of the vessel of a side branch, you'd actually have to do the OCT of the side branch. But we were the first one, actually got published, called the Orbit FFR trial, where we stented across, we did the FFR of the side branch, we did a OCT of the main vessel to show exactly what we are showing right now, that your side branch, you see that you can see, do a 3D, show the ostium. That's where you are. Can you show the OCT now? That's the side branch. The Kiski is showing. See that side branch ostium there, as well as the side branch ostium. So it looks very good on the imaging, because we have a correlation in Orbit FFR saying when you see that, and if your area is 0.8 millimeters or less, that's the only time you will have some issue or compromise of the side branch. Here it does not look that way. So even by imaging we have confirmed it, but otherwise I think people like all of us who are here today, who based our career on angiography and our eyes and the visual look, the angiographically diagonal looks very good pre and post procedure.
Okay, so we
go back to the apps now. So they can see all the various apps that are out there. The Bifurcate was the first app, and I think all the steps I described today, the wiring technique, types of wire, when to go to the side branch, how to wire side branch, everything has been described in there.
Okay. All right. So we conclude now. Samir, you take us and comment from Dr.
Absolute.
Colombo.
Dr. Colombo, any final comments from you?
I think, first of all, congratulations for conducting such a nice and teaching case. I want to make some consideration in the question. The Alpheus trial, should we conclude that peri-procedural MI are not platelet related, or we need another study with a more potent platelet antagonist like Cangrelor to really close the issue?
Yeah. So, but remember, in 1 month, you are giving both the drugs. So, key is that our stent designs have become much better. So that basically is. So what it showed, all those MIs higher in the clopidogrel group compared to prasugrel and ticagrelor was because of the old thick strut stents. So now our MI rate is low and it's equal in both the groups. So that basically is. But yeah, question always comes that once you come out of the initial 1 month period, are you going to have a trouble after on with this?
Yeah, I agree. Yeah. I think, but I'm just concentrating to the peri-procedural MI.
Yep.
Right.
We still, if you take very strict definitions,
yes,
the peri-procedural MI is not zero. How can we decrease it? should we improve on the stent or should we improve on the platelet inhibition?
I would say we improve on the stent because platelet inhibition improvement will give rise to more bleeding. And we learned that that's going to give a trouble.
But even if you just confine platelet inhibition to 1 hour, 2 hours,
Yeah.
because with cangrelor, you only act during the procedure.
Right.
Then you stop cangrelor and you can give clopidogrel because the peri-procedural MI is something that happens during the procedure.
That is correct. Yes. So I think that's a very provocative concept that just give it for 2-3 hours. I know some data have shown that led to the IV cangrelor approval in United States by decreasing intraprocedural thrombosis. But those all were done with a clopidogrel. Question is that do you need to use clopidogrel plus IV cangrelor or in these cases, or you use a stronger antiplatelet therapy of ticagrelor prasugrel in a stable CAD. So that's where it comes down to. In the stable CAD, it looks like that it doesn't make a difference.
Yeah, but in stable CAD, I would not give for 1 month. Why to give for 1 month? You increase the bleeding.
Yes.
You just want to lower the peri-procedural MI. The case is closed in 2 hours.
That is correct. Yep.
Dr. Colombo, thank you so much for joining us. Thank you for sharing your intellect and your experience, and have a Merry Christmas and a Happy New Year.
Thank you.
Thank you.
To our viewers, we complete the last session of 2020, and we'll see you in the new year on January the 19th.